We're going to have different frontline therapies, Walt. You know, how are you going to select your second-line therapy? Does the frontline therapy influence that? Does the response or tolerance to the frontline therapy influence that? Used to be we'd go from VEGF-targeted therapy to VEGF-targeted therapy, then we got IO therapies. Now we've got, seems like, more confusion and options. Can you give us some clarity on your treatment selection?
Well, the most clarifying thing is that this is good for patients. We have options and we have choices. And I think that that's a good thing. I think that the pharmacology that is most under-recognized is that a TKI after an IO monoclonal antibody is different than some other kind of second-line therapy. And it simply has to do with the fact that these antibodies have very long half-lives. Remember that we can give them every month successfully, and the half-life of these drugs means that the antibody is sticking around in the serum at reasonable levels, probably above the level where you need efficacy, up to 4 months after you've given the therapy. And there are studies that have suggested that the level of the antibody on circulating lymphocytes is longer than anyone's measured, which is at 6 months. And we have no idea what's going on in the tumor microenvironment. So I think that one of the things that I'm paying attention to is whether the VEGF inhibitor after a IO inhibitor may really be combination therapy. And I think that where this comes up important clinically is that we know that certain combinations, for example, pazopanib with some of the IO inhibitors, have not played well together in terms of toxicity, and that leads me, for example, to use things like axitinib or cabozantinib in the post-IO setting because I know those combinations are safe.
Tony, what are your thoughts on this?
Yeah, what we know is that TKI can have activity pre-IO and post-IO, and we have reported on that extensively. Interesting enough, could they have a better, activity? And if this better activity is because the immune milieu or whatever, tumor microenvironment is prepped, or because Walt is saying that there is still some antibody there, acting up. I think one of the data we have that is interesting, small number of patients with Meteor, where if you look at the patient, very small number of patients that were exposed to prior IO versus not, the progression-free survival, hazard ratio was really much better in patients who had prior IO. I think that begs the question of sequential therapies, starting by IO, following it with another IO, or IO followed by VEGF, or the reverse sequence. I have a small problem in that. I think from a safety perspective, it's excellent. Let's not forget the attrition rate. For whatever reason, patient who just doesn't want anymore anything, and let's not forget that in medical oncology we're able to cure metastatic disease usually. Forget about precision medicine now for a while with combination chemotherapy, and sometimes when you give 4 drugs, 3 drugs is better than 2. I mean, we know that in testis cancer. So are we missing an opportunity to make a CR or deep response and perhaps cure? I don't like to use that word, right and left, better with 3 to 4 drugs at the price of toxicity, where if you start by 1, patient has a side effects or just, doesn't want any more treatment, and you lose that opportunity. So there will be room for sequential, trials, and there will be room for, the most aggressive combination trials.
Well, I think it's essential, and we're all at, academic institutions that have the existing technology, that we learn how to work with our scientists who we need to teach the clinic and what are our clinical problems, and study these cancers so they can help us understand how tumors are acquiring resistance, which I view differently than adapting. Acquired resistance to me is you give drug IO and within 4 months the tumor's already taken off. They didn't adapt, they were just resistant. And the same thing occurs with TKs or mTORs. Why is that? And what do we need to learn from that? And we have to learn from the good patients. You know, how many of us in this room biopsy a good patient response to understand why they were good?
It's hard to justify.
Right.
Yeah.
You know, I might, call the thoracic surgeon and say, hey, can you take this nodule out? I want to learn why it's better. Yeah. And that's the reason. I mean, he knows it. Yeah. You know, he knows when he sees the patient, because he's going to see the patient's healthy. Yeah. Patient's fine. Why do you want this done? Because I want to understand why this person did well and his 10 counterparts did not.
And Rich, in terms of picking a TKI after IO therapy, what are your thoughts on that? Walt brought up some issues around, subsequent toxicity risks and whatnot. How do you decide which TKI to do next?
That's another great question that I struggle with, honestly. I think without any randomized data to help guide us, of course, so you're left just, trying to choose from the plethora of TKIs that are out there. And then if you even think about, well, Votrient, or excuse me, pazopanib is in the front line. Is it even approved in the second? And what about sunitinib and all? So there's all these other things. You have second line approvals. So it's a tough decision, but I think right now, based on Meteor at least, that was a kind of a second line trial. It had survival. That's becoming my first TKI of choice, let's say if I do IO in the front line. But I can't say that's a really scientific based answer.
Sure. I think it's an area we need more data for sure.